and architectural deterioration of bone tissue, which hence causes bone fragility and susceptibility to fractures. We are very well aware about the basics, the primary osteoporosis, the secondary osteoporosis, the most commonly primary osteoporosis. Today, we are going to talk about is the estrogen deprivation after menopause. That is the post-menopausal osteoporosis. And there are lots of drugs which should be known to our postgraduates and all the faculty members, because that is not uncommon, along with the lots of group of drugs which are commonly used, which may cause fractures. So there are fragility fractures, and these are defined where there is without minimal trauma or with minimal trauma, the fractures risk is high. So they need to be addressed. If we see the burden, the WHO data, if you see 1 in 3 women over the age of 50, which is a postmenopausal age, they will experience an osteoporotic fractures, and it is a major cause of morbidity and mortality, especially in the postmenopausal stage. The Indian scenario is not much different. 50 to 60 million Indians are being affected. Here, as my moderators were talking about, the difference lies is that the peak incidence of osteoporosis is much earlier, immediately after the postmenopause. The background being they are vitamin deficient, they are low calcium intake, there is societal changes which can be seen from the Caucasian population. The estrogen deficit seen in the postmenopausal phase, leading from the rank L pathways where there is without estrogen, there being an excessive unhinged expression of the rank L, the osteoclast hyperactivity and uncoupled remodeling may be responsible for this osteoporosis. If you can see the menopause, there is an estrogen deficit causing increased bone resorption with decreased bone formation. So the remodeling gets affected. There is a negative bone balance. They may have various early or the late presentation, and hence resulting in osteoporosis and fragility fractures. Other features also, other than the estrogenic effect, the aging also induces lots of oxidative stress. The associated chronic inflammatory disease in the postmenopausal may aggravate the situation, and on the background of the chronic vitamin D deficiency, calcium reduced intake, they may also produce this. So I'll just enumerate some of the clinical features which should be there in because we see the postmenopause, as we've talked about, an average lifespan of an Indian is around 70 to 71 years. Now, as Dr. Meena ma'am was saying, around 20 to 25 years, the female is in the postmenopausal phase. Here, you need to be good at your history taking, and you have to have a targeted physical examination. Unless the fractures is not there, they may not get to you for the diagnosis and the treatment of osteoporosis. So mostly when these postmenopausal women are visiting to you for other illnesses, we need to be aware about some of the risk factors of osteoporosis. Major risk factors: the advancing age, the female sex, the Asian and the Caucasian ethnicity, personal history, previous history of fractures in the adult, family history, especially in the parents, low body weight, short stature, premature menopause, with the current history of smoking or long-term steroid for minimum dose of 5 milligram for more than 3 months should be made you suspicious that this patient is also having osteoporosis. They may be silent or asymptomatic. The risk of presence of this osteoporosis may result in the fragility fractures or frequent falls. There may be additional risk factors of impaired vision, estrogen deficiency, poor health, recent fall, the low calcium intake, low physical activity, and excessive alcohol use, which is increasing nowadays in both the sexes. So we have already talked about the what similar is being defined by the WHO, the environmental factors, which can also be calculated. You can say the calcium intake using the quick dietary calculator, where the calcium intake can be assessed by talking about the lots of daily dairy products and all the calcium sources, how much the patient is taking. The protein sources can also be assessed, the physical activity, the sun exposure, they all can be assessed with the chronic diseases if the patient has. So going ahead and asking about these risk factors or enumerating and looking for these may be the first step where you can make a diagnosis of osteoporosis. So prior fragility fractures, there is a risk, they may have wrist fractures, Colles, hip or spine. So the strongest predictor of future risk is the prior fragility factors. Without minimal trauma or just a fall, the patient has fractures. Sometimes they may not have any symptom, only the posture has just got changed, they may be unnoticed spinal fractures where there is only loss in the height, which should be make you suspicious. Get a thorough history of drugs which are osteotoxic. The steroids we've talked about, the prolonged PPI, which is very, very common, the antiepileptic drugs, the aromatase inhibitors, which are required for breast cancer, and even the osteoporotic drugs, overuse of the bisphosphonate, where there is a oversuppression of the osteoclast, and also of the sudden withdrawal of the denosumab may be other causes of increased chances of osteoporosis. So there may be fall history may also be there, because we are actually we want to catch the patient early without any already the patient, if they have not taken the fall. So the prevention of fall should be the goal. The environmental hazard should also be assessed. The visual impairment, especially in the diabetic patient or the elderly patient, the neurological symptom like neuropathy or cognitive decline should also be assessed. So coming to, as per se, we've talked about the asymptomatic osteoporosis. What could the symptoms of osteoporosis patient may present? The women may have fractures, as we talked about, or they may have some severe pain with sudden onset, with minimal trauma, or some abdominal pain or radiation pain. Generalized body pain may be more in severe in osteomalacia and metastasis. Fall assessment is recommended. Patients having associated deficiency may have weakness in the proximal muscle, which may result in difficulty in squatting, climbing stairs. Tenderness on the pre-tibia or the sternum may be elicited. A risk assessment of other comorbid conditions should be done. Diabetes, hypertension, thyroid, and other disorders, cancers should be done. Family history of osteoporosis and other disorders should also be known. The prior fracture risk should also be known. The over-the-counter drugs medication should be asked. The tobacco, alcohol use also should be talked in the medical history. Let's just take a simple case before proceeding. What next to go and order for the investigation? This is a postmenopausal 61-year-old female, known hypertensive on hyperlipidemic with on diuretics and statins. She is a smoker. Her mother is a diabetic, and father is also has suffered from colonic carcinoma. She has been regularly undergoing colonoscopy and mammography and pap smear examination, as told by the consultant in charge. Her vitals seems to be under control. So she primarily came for the routine checkup for her. And what else can be important in this female? Just on probing some questions, she never liked dairy products, rarely take calcium supplementation, went through menopause at the age of 55, which is usually around 45 to 50 in our scenarios. Last year, her mother had to suffer a hip fracture. Her weight is 56, height is around 5'4", and which there is a loss of half inch. Both men and women experience an age-related decline in BMD starting in midlife, and women experience more rapid bone loss in early years following menopause. So in this patient, there is a history of fragility fracture and first-degree relative. She is a low body weight with a history of smoking. There is an estrogen deficiency and low calcium intake, other than other parameters which are less obvious. So this patient has several risk factors for osteoporosis. So what physical examination can help? So usually they are normal in early disease, but they should be done to assess immediate fall risk. The spinal deformity, you have to inspect the thoracic kyphosis, because as it's more progresses, because of the multiple anterior wedging compression, they may have a diverger hump. They can check for the spinal tenderness for acute or subacute fractures. Simple assessment of the proximal muscle using the timed up go test, or a patient has having difficulty in rising from the chair, may suggest the risk factors for frequent falls. So get up and go test. Another being the occiput wall test, which also about the vertebral fractures, the lumbar fractures, and the kyphosis should be assessed. We'll talk in detail in the coming slides. So the vertebral fractures are the most common osteoporotic fractures, which are asymptomatic up to two-thirds of the cases. So you have to look for the height loss. If there is a wall occiput distance is more than 0, or if you're able to insinuate more than 2 fingers in the lateral thoracic spine, the lumbar spinal fractures should be assessed, and progressive weight loss of more than 2 of the height should be suspected. So some tests which can be advised after the physical examination can be a battery of test: bone chemistry, the calcium, phosphate, phosphorus, alkaline phosphate is the PTH, the kidney function, the liver function, the vitamin D and PTH, along with the other hormones, to rule out the secondary osteoporosis should be there. We know the gold standard test being the DEXA test, which is a dual energy X-ray absorptiometry, which measures the bone mineral density at the lumbar spine, total hip, or the femoral line. The normal score being more than -1. So it is essential to rule out other secondary causes, as we have talked about. We are having lots of population in the menopausal age associated with other chronic disease, so that can be helpful. DEXA being the gold standard. X-ray should be recommended in a diagnostic protocols for osteoporosis, especially the features can be seen in advanced bone disease. US-based, ultrasound-based bone densitometry should also be helpful, and there are certain bone turnover markers which not only can be helpful in diagnosis, but definitely in prognostication and seeing the treatment response. Summing up the criteria for diagnosis of osteoporosis as published by the Midlife Journal of Health, the diagnosis of osteoporosis is by the presence of fragility fractures, clinical or radiological, or BMD of T-score equal or below to -2.5 in a postmenopausal women. The gold standard method of BMD testing is a dual X-ray DEXA, and this is standard test to be used. The clinical densitometry diagnostic criteria may also take the T-score. We are very well aware. The Z-score can be used, especially in postmenopausal women, just to evaluate if they think there is secondary osteoporosis. Otherwise, Z-score will be more evaluated in the perimenopausal women, adolescent, and children, which will be in accordance with the age and sex matched individuals. So what the various guidelines says, I think ma'am will be taking. I'll just sum up the all women beyond 5 years of the natural menopause, or less than 5 years, but with risk factors, with fragility fractures, with secondary causes, or they are having radiological evidence of osteopenia or vertebral compression fractures. This is by the position statement by the International Society of Densitometry, where they recommend, irrespective, like 65 years of age, they and older, irrespective, they should be done, or lesser than that, with the various risk factors should be sought for a BMD. Before initiating pharmacotherapy for osteoporosis, especially in Indian females, they should go for DEXA scan, and that should be scheduled for 1 to 5 years. This we all are aware about the normal, the osteopenia, and the severe osteoporosis using the BMD scan. various guidelines, as if you see the A's, the European Society Frax assessment seems to be one of the good web-based algorithm to check the high-risk individual with the 10 years probability of major osteoporotic fractures, the clinical risk of smoking, steroids with the femoral neck BMD may be required. As you can see, there's a Frax score a calculator which can be used. Certain bone turnover markers like serum C-terminal telopeptide, which is a marker of bone resorption, and procollagen N-terminal propeptide P1 and P, which are the markers of formation. They can be used for monitoring the treatment and compliance along with the DEXA scan in a 3 to 6 month interval versus 1 to 2 years of DEXA scan. Certain places, TBS trabecular bone score to extract the microarchitecture are also being used, and quantitative CT provides a volumetric density where the confounding factors of severe osteoarthritis can be seen. The central DEXA is the gold standard using the posterior anterior lumbar spine, the femoral neck, or the total hip. Other are less commonly used. We've talked about the quantitative CT and the peripheral DEXA, which is like we are using in the clinics for the screening, the calcaneum USG or the other peripheral DEXAs. They are not recommended for diagnosis and management of osteoporosis. If you screen someone, you can ask them to go for DEXA scanning. So these are the US data about the cost, and this is quite an old data. So we've talked about T-scores, which are used to make diagnosis of osteopenia and osteoporosis. These are normal deviation from the mean density in a normal sex-matched individuals, and this is used for diagnosis. Z-score is used for bone loss and perimenopausal age, where this is the mean density is used for age and sex control. So this is the T-score, which we from the normal to the osteopenia to the osteoporosis. Our patient went for DEXA and her it was around 2.5, which is somewhere lesser than 2.5 makes it a patient of osteoporosis. And as you can see, the guidelines T-score below -2 with no risk factor or -5 in either of the societies mandates treatment. We have to look for the other individuals, or if you think there are lots many endocrine causes, nutritional causes, the drugs which we've talked about, and other chronic condition should be assessed for secondary osteoporosis, and a list of battery of tests can be done to rule out osteoporosis. So in this patient, she doesn't have any other secondary causes of bone loss. Lab studies were normal. Treatment we're about to hear in the next talk. So to conclude my talk, to prevent and treat postmenopausal osteoporosis, women should be encouraged to perform weight-bearing exercise, quit smoking, and to optimize calcium and vitamin D intake through diet and supplement. Drug regimens are effective and well tolerated in PMO patients. Osteoporosis is asymptomatic unless a fracture occurs. Fracture risk is defined by BMD and clinical risk factors. For treatment purposes, combining BMD with clinical risk factors provide a better estimate of fracture risk. We simply should not treat T-scores, but must take a patient's full clinical status into account to make a therapeutic decision. Early diagnosis in the asymptomatic period is essential, and timely management can prevent morbidity and mortality. Osteoporotic fracture risk screening in large scale in whole group population is not cost effective. So selective approaches, that is targeted screening for disease detection, are advocated. With this, I'll stop my sharing of my slides, and I look forward for ma'am to continue the next leg of the lecture, because all we do get it, osteoporosis needs to be treated, and what's the best management. And according to the guidelines, I think Dr. Jayashree would be the best person to talk about it. Thank you.
Thank you, ma'am, for an excellent talk. And I would now like to introduce our next speaker, Dr. Jayashree Swain. Ma'am is DM Endocrinology, working as a professor in the Department of Endocrinology at IMS and SUM Hospital, Bhubaneswar. And as mentioned by Dr. Anupam, ma'am would be taking to us about the recent guidelines in the management of postmenopausal osteoporosis. Over to you, ma'am. Dr. Jayashree, we are not able to hear you.
Just a minute. Yeah. Sorry. Hello, good evening, everybody. Am I audible?
Yes, ma'am.
Yeah. So I am very much thankful to Professor J.K. Sarma sir, Dr. Meena ma'am, and all the members of the IPF for giving me this opportunity. And Dr. Anubha has made my job easy, and he cleared so many aspects of the postmenopausal osteoporosis regarding the screening. My job is management of the postmenopausal osteoporosis. What about these recent guidelines and how to treat? So coming to this screening, Madam has covered so many aspects. So in Indian setup, this osteoporosis is occurring earlier in the Indians. So in Indian Society of Bone Minerals Research, ISBMR, they recommended the screening of DEXA in the women aged 60 years or older or men aged 65 years or older, irrespective of this clinical risk factor, what Madam has described, and or postmenopausal women younger than 60 years with this probability of osteoporosis and clinical risk factor profiles are there, we may go for screening. And menopausal women with menopausal transition, those who have this specific risk factor like the low body weight, prior trauma fracture, or these high risk medications, we have to screen all these patients. And those who have this fragility fracture before the age of this 50, or these women with the conditions like secondary cause like rheumatoid arthritis, diabetes mellitus, malabsorption syndromes, or those who have these steroids, maybe these prednisolons more than 5 milligrams or equivalent for more than 3 months, they are the suitable candidate for screenings by the methods what Dr. Anuha has described nicely. The next, we are following that something is different. Next, this indication, this is starting treatment to whom we are going to treat. Those patients who are these vertebral fractures that is detected clinically or by the vertebral imaging, or non-vertebral fracture of the area like hip, wrist, or humerus, or individual more than 50 years with D scores more than minus 2.5, and individual with the osteopenic range, that means T score minus 1.5 to 2.5, and clinical risk factors. And when you are going to calculate the FRAC score, then major probability of for 10 years probability of major osteoporotic fracture risk is more than 10%. These are these patients. And in type, remember one thing, in type 2 diabetes, we have extended the score to the 2. It is not 2.5. So these are the suitable patients. We are going to start the treatment. So I may be a little bit different from that of the Indian scoring system. So if we are following the National Osteoporosis Federation's criteria, then Indian specific FRACs may underestimate the fracture risks. We should, while calculating the FRAC score risks, we should be very much vigilant regarding the what guidelines we are following. So next, coming to that, before going to treatment, we should have some biochemical investigations with us. The mandatory biochemical investigations with us is completely blood count, calcium phosphate, alkaline phosphatase, renal function test, liver function test, 25 hydroxy vitamin D, and the intact PTH and thyroid stimulating hormone. And as you know, for the secondary, to rule out the secondary causes of the of the osteoporosis, we have to go for the DEXA. If you are suspecting Cushing, you will go for the DEXA suppression test. For the celiac disease panel test, you may go for that. And if hypogonadism, you may go for the gonadal steroids. These are the tests to rule out the secondary causes of the osteoporosis. So coming to the general management of the osteoporosis, if in general management you have to look for this 25 hydroxy vitamin D level, and this optimum level should be more than 20 nanogram per ml. And for this, we have to supplement 100 to 200 IU of a daily maintenance therapy to maintain these levels. And similarly, calcium intake should be adequate, whether it is in from the diet or from the supplement. It is in the form of 100 milligram per the day for a woman more than 50 years. And limitations of the alcohol intake, cessation of the smokings, active lifestyle, that means weight bearing exercise and also balance exercise, and counseling regarding these risks of the fall should be there for this management. It is included in the general measure in the management of the osteoporosis in a postmenopausal woman. Next, coming to what are these pharmacological agent, and it is beautifully described in these pictures. This is the pictures of this bone remodeling and the therapeutic target for this osteoporosis. We have osteoblast and osteoclast and osteocyte, and it is formed from the mesenchymal cell. Osteoblast is the bone forming cell. Osteoclast is the bone resorption. It is meant for the bone resorption, and osteocyte is for the signaling. It will form the bone mass, and it will give the signal for this bone remodeling. So we have another pathway also, the WNT, sclerostin, beta catenins, and that of the decay pathway. That is extra pathway I will cover later. But rank ligand and OPG are these signals which is driven by the osteoblast, but it will act on the osteoclast. We have target for the rank ligand, we have target for the OPG, and we have target for the osteoblast and osteocyte. So this is our therapeutic target. So among that, we have anti-resorptive agent and we have anabolic agent. Anti-resorptive agents, they will act on the osteoblast. So anti-resorptive agent, they inhibit the bone resorption by suppressing the osteoclast, and it's slowing the bone remodeling cycles. So it allows the bone formation and matrix formations. Among these anti-resorptive, we have bisphosphonate, and as we all know the mechanism of this bisphosphonate, it is a analog pyrophosphates that bind with the hydroxyapatite crystal and inhibit the osteoclast attachment, and prevent it causes its apoptosis. So one important thing is for bisphosphonate is that it is distinct from these other osteoporotic agent. How? It is positive effect persists for several years after the discontinuation of the treatment. We have oral bisphosphonate and we have IV bisphosphonate. Among oral, we have alendronate, which is weekly, ibandronate, monthly, residronate, maybe weekly or monthly. And IV, we are giving the zoledronic acid in the dose of the 5 milligrams. And for prevention, you may give you annual twice in a week, twice in a year, and for treatment annually. Ibandronate is also there with us IV. So let us have a pictorial representation of the actions of the bisphosphonates, and it will inhibit the enzyme. Particular enzyme is the farnesyl pyrophosphate synthetase, and that the inhibitions of the enzyme lead to the apoptosis of that osteoclast. So this inhibition is more in zoledronic acids than residronate, than ibandronate and alendronate. So we are basically nowadays giving the nitrogen containing bisphosphonate rather than this other bisphosphonate. So this is a beautiful slide in which I have taken this every molecules of this bisphosphonate and its action. So according to this recommendation, this post-menopausal osteoporosis for prevention and treatment, alendronate, residronate, ibandronate and zoledronic acid is recommended. If you look to this comparison between all these bisphosphonate, zoledronic acids has 77% decrease in these vertebral fractures, and residronate has 59% decrease in these non-vertebral risks. So this is the two molecules which have a significant benefit in these vertebral risk fractures and non-vertebral risk fractures. So before prescribing these zoledronic acids, we should have this risk categorization of our patients at high risk, low risk, and moderate risks. If somebody is having prior fracture, fragility fracture, and T-score is more than 2.5, minus 2.5, and frax calculation is more than 20%, for the major osteoporotic fracture, it is coming on the high risk. And if somebody is having these fractures, no fracture with T-score is less than 0.1, frax calculation is less than 20%, then it is coming on the low category. And in between that other moderate risks is there. Why I am going for the risk categorization? Because of the starting treatment. So in high risk treatment, high risk category, you may start treatment with the bisphosphonate. In low risk, there is no treatment, but moderate risk you may consider. And the duration of the treatment varies from that of the 5 to 10 years in the depending on the risks. And that should be a drug holiday for bisphosphonates. And the drug holiday, you can take the drug holiday in the moderate risks is than the high risks. High risks, you may continue the treatment drug, but you can take short drug holiday. Drug holiday is important for bisphosphonate because of it will have some protective effect on the atypical femur fractures. So follow-up in these high risks and low risks depends on the risk categorizations according to the 1 to 2 years. So there is some contraindications for the bisphosphonate. When somebody is having EGFR of less than 30, or vitamin D deficiency is the contraindications, and have some side effect of bisphosphonate, like oral bisphosphonate may have the GI irritations, and IV bisphosphonate may have these acute phase reactions and fever-like patient may have these fever-like symptoms, and atypical femur fracture and osteonecrosis of the jaw is the complications of the bisphosphonates. Next, anti-receptive agent we have is denosumab, and it is a better molecule, but is humanized monoclonal antibody. It is attached to the GRAC ligand. It inhibits the activation of the osteoclast, but it is beautifully given in the pictorial form. And the dose of the denosumab may be 60 milligrams subcutaneous every 6 monthly. As this, there is certain advantages of the denosumab over the bisphosphonate. What is that? When the EGFR is less than 30, you can prescribe the denosumab, but you can't prescribe the bisphosphonate. This increase in the BMD in the stage, even if stage 4 CKD has been established in the freedom trial with the denosumab. There is certain adverse event like that of the osteonecrosis of the jaw and subtrochanteric atypical fractures of the femur, hypocalcemia. The hypocalcemia risk is more when you are treating with a CKD patients. So, denosumab, one of the important thing is that it should not be the dose. Denosumab should not be missed. Once you stop the denosumab, again after 24 months, the patients will come to that of the previous BMD. So, denosumab should be continued indefinitely, or it may be replaced with the bisphosphonate in our clinical recommendation or clinical trials, as it is not persist in the skeletons like that of the bisphosphonate. So, the dose should be 6 monthly. So next is the calcitonins. It has a receptors on the osteoclast. So it is recommended for the postmenopausal osteoporosis. You can prescribe by the nasal route, by the subcutaneous route, and the dose is different. It will effective on the spine fracture, but it is not effective for the non-vertebral fracture. So coming to the estrogen and HRT in the postmenopausal women, it is the only for prevention of the osteoporosis under the women of 60 years of the age and less than 10 years of the post-menopause. If the person is having, if the woman is having low risk of the deep vein thrombosis, and those who have these bothersome vasomotor symptoms and they are not tolerating bisphosphonate and denosumab, they are the suitable candidate for the HRT. And those patients should not have the myocardial infarction, strokes, breast cancer, or other contraindications for the HRT. And moreover, that patient is willing for the menopausal HRT is the most important. So next is the SERM, selective estrogen receptor modulator. Raloxifene is one of these common agent. It is given 60 milligrams once daily, and there should be some specific patient characteristics that it's used those who have this low risk for the deep vein thrombosis and a high risk of these breast cancers, and this bisphosphonate and denosumab is not applicable in that patient. You can go for this SERM. treatments. So from these guidelines, I have taken these anti-receptive agents, bisphosphonate, estrogen, SORM, and RAG ligands, and these recommendations from these literatures I have taken in the entire table. So next coming to that of newer drugs among these categories, so many other drugs like cathepsin K and the integrin antagonist and chloride channel inhibitors are there in the pipeline. It will come to this come recently to us. So coming to second part of my presentation is anabolic agents. We have two type of anabolic agents at present. Non-WNT related anabolic drugs, that is teriparatide and abaloparatide, WNT related anabolic drugs. So if I will discuss for this non-WNT related, that is teriparatide and abaloparatide, it is approved for the post-menopausal osteoporosis, and teriparatide is given 20 micrograms daily for 2 years, abaloparatide 80 micrograms daily for 2 years, and in all the case you have to rule out this Paget disease, and there is a black box warning for this teriparatide, that is osteosarcoma. It is related to that of the if you are treating more than 2 years, the risk of osteosarcoma, which is seen in case of the animal models. So particularly coming to the literature, teriparatide, there is decreased fracture, vertebral fracture risk is 65%, non-vertebral fracture risk is 50%. So the side effect are nausea, flushing, hypotension, mild hypercalcemia may be there. Discontinuation of these teriparatides result in this further bone loss. So after stopping this teriparatide, you may go for this anti-receptive therapy, and that is the one of the important informations I want to give here. So coming to abaloparatide, it is analog, PTHRP analogs, and it increases the bone mineral density without increasing calcium like that of the PTH, and the dose I have described. So this is the beautiful pathway of the WNT pathway. As we know, this pathway, it is the beta-sclerotin, beta-catenin, sclerostin, DKK, GSK3. All these are it is alternative pathway for bone remolding, and it's the newer things we have discussed so many times. So that is WNT antagonists are with us. That is WIF1 and Fragile-like receptor proteins antagonist, sclerostin and DKK1. So with us, the newer molecules antibody to the sclerostin, that is romosozumab, the blosozumab is available and trials are there. It is recommended for the postmenopausal female with severe osteoporosis, and the dose of romosozumab is 210 milligrams subcutaneously monthly for a period of 1 year. And you should have some, it has its own demerit that high risk cardiovascular patient, you can't prescribe that. The side effect in the trial, that is frame trials, and it has been seen that osteonecrosis of the jaw and this atypical femur fracture has been seen with the sclerostins. So I have taken all these recommendations from these guidelines, that is PTH, that's anabolic agents like teriparatide, abaloparatide, romosozumab, blosozumab. What is this literature's evidence and recommendations? So, so many newer therapies among these anabolic categories are with us, like that of the inhibitors of what I have described, that is anti-sclerostin inhibitors, monoclonal antibody to decay, and the inhibitor of GSK3 beta, and Fragile-like receptor inhibitors. So this is the recommendation by the ICMR. Quickly, I'll follow that things. If somebody is having disease, some postmenopausal lady is having vertebral fracture, the first recommendation should be teriparatide, followed by zoledronic acids and denosumab. If somebody is having hip fracture, zoledronic acid is the first choice, followed by denosumab, and teriparatide has limited value in these hip fractures. If somebody is having high risk individuals without fractures, so bisphosphonate may be the first choice, whether it is oral or IV, and denosumab followed by denosumab. Teriparatide, you may consider if it is BMD is very low. With low and moderate risk individuals, oral bisphosphonate may be the choice. So combination, sometimes we are giving combination therapy or sequential therapy. In combination therapy, when the patient is very high and high risk and immediate fracture risk is there, in that case you may go for combination. Among the combination, teriparatide denosumab is scoring high, and then the teriparatide bisphosphonate. So sequential therapy, similarly, teriparatide should be followed by the anti-reserptive, and if somebody is unresponsive to the anti-reserptive therapy, you may go for the teriparatide combinations along with the anti-reserptive therapy. So during this first follow of 3 months, followed by 3 to 6 months, and followed by yearly, annually. What you will do in this follow-up? By history, as madam has described, for osteonecrosis of the jaw and for atypical femur fracture, we have to go for look for that pain, and also for the kyphosis, scoliosis, we have to go for the different tests madam has described. And similarly, physical examinations for the bony abnormalities we have to look for. Some radiological investigations, X-ray regarding that of the kyphosis, scoliosis, and jaw necrosis of the jaw, and BMD. And some BMD, according to the latest Endocrine Society guidelines, BMD by the DEXA at spine and hip, if you can do for, if you may go for every 1 to 3 hours for the treatment response. There may be failure in this case, in sometimes. Failure when there is a BMD improvement is less than 4% in total hip, less than 5% in the femoral leg, you should take it. It is a failure of the therapy. In that case, you may go for this alternative one. So bone turnover markers, that is resorption marker is CTX, and formation marker is PINP. There is 30% reduction in the resorption markers and 20% improvement in the formation marker. It's in the follow-up, you can go for that. So to conclude, osteoporosis educations regarding these fall preventions should be given to each and every patient along with the therapy, regular monitoring of the therapy. So these are my reference I have taken from this recent. So thank you for your patient hearing. Over to you, the organizer. If there is any questions, I will be happy to approach on this.
Thank you so much, ma'am, for a very enlightening presentation. I would now like to request our panelists to please join, and I would like to introduce the first panelist, Dr. Vishal Kaura Agarwal. She is a senior consultant rheumatologist at VLK Max Super Speciality Hospital, New Delhi. And Dr. Devesh Jalan is a professor at Department of Orthopedics, Central Institute of Orthopedics, Safdarjung Hospital, New Delhi. I would also request the speakers to stay online and we can start the discussion. So we have, I would like to set the ball rolling by asking Dr. Vishal Kaura Agarwal a question. Ma'am, how do you manage osteoporosis in patients on long-term glucocorticoids who have been taking it for a very long period of time?
Hi. Good evening, everyone. Thank you, organizers. Thank you, especially Dr. J.K. Sharma and Dr. Meena, to have invited me here. Thank you for giving this opportunity. So, Dr. Pooja, on glucocorticoid long-term treatment, of course, first of all, I will start with the very basic calcium and vitamin D supplementation. As we know that glucocorticoids, they give a negative metabolism for calcium. So only supplementing calcium adequately and vitamin D can have a significant protective effect. And according to the American College of Rheumatology, so 1000 milligrams of elemental calcium and vitamin D is essential. So that is something we have to reiterate again and again at every visit, that at least adequate calcium and vitamin D and other lifestyle changes. Of course, Dr. Jayashree has already given a very good talk. So weight bearing exercises and of course stopping smoking. But anyways, those who are at high risk, we have to give pharmacological therapy. Those who are post-menopausal and men more than 50, we start with therapy. As Dr. Jayashree said, that, we have bisphosphonates and we have teriparatide. And denosumab, we do not have too much of experience, but of course, with bisphosphonates and teriparatide, those who are at risk, those who have osteoporosis and one risk factor, we start with bisphosphonates and continue with that and monitor it. Maybe in the first, after a year, you do a repeat BMD. But if the patient is doing well, then you may not have to repeat it every year, then maybe every 2 to 3 years. If doing fine, then we continue with bisphosphonates. But if there is it turns into a high risk, maybe a fragility fracture, or if we find that the BMD has gone down, so we switch over to, if it goes into that category of severe osteoporosis, then we switch over to teriparatide. But those who are premenopausal, so there we have to keep evaluating at every visit, and we do not start pharmacological therapy there and then. If the lady falls into that category of high risk or has fragility fracture, then of course we need to start with the therapy, pharmacological therapy. And in men also, if they're less than 50, we do not give pharmacological therapy there and then. These are in generally those patients who have vasculitis or myositis. If we find that we are able to spare the steroids in first 6 months to 1 year, there they are in a good bone health. But those who develop those patients who have to give longer, or those who get some fragility fracture or they have multiple risk factors, those thin and lean and has family history of, there we start with therapies there and then.
Thank you so much, ma'am, for going into the depths of this management. I have another question for Dr. Devesh Jalan. Sir, how commonly are fractures seen in the postmenopausal woman age group in your clinical practice as an orthopedic surgeon?
Very good evening to all of you. And before answering that
Evening, sir.
question, I would like to thank the respected Dr. J.K. Sharma and Dr. Meena Chhabra ma'am and the entire executive team of IPF Women's Wing for giving me this opportunity. And as has already been discussed, that postmenopausal osteoporosis is a silent disease. So most of the time they present to us with fractures. So I think the orthopedic surgeon is probably one of the first person who sees these patients. So in like we mostly see these patients in emergency setting, and in our emergency setting we see 8 to 10 patients of postmenopausal osteoporotic fractures very commonly. And most of these fractures are predominantly hip fractures, which include neck or femur or intertrochanteric fractures. Colles fractures are also very common. After intertrochanteric and hip fractures, we see Colles fractures. The vertebral fractures are not that commonly seen in the emergency because they don't have a very acute presentation initially, as these patients have mild pain for quite a long time. They have some decrease in height. So most of the time, these vertebral compression fractures are missed until unless we have a significant trauma which points in that direction. So these fractures are very commonly seen in the emergency. Majority of these fractures are mainly located at hip, which is a very common fracture, followed by wrist, which is Colles fracture, and then we see very commonly vertebral compression fractures, which is mostly we see in the routine OPDs.
So my question is, doctor, do you routinely prescribe treatment for osteoporosis once the patient has one fracture and it's a postmenopausal woman? Or would you do the DEXA scan, and do you do 3 sites, hip and spine and forearm, or would you do 2 sites?
But most of the patients we prescribe 3 sites, but we give more importance to the spine and the hip because these are weight bearing joints. And obviously, if we find any changes in these two areas, they are much more significant than what we see in the wrist per se. But if the patient has come to us with the Colles fracture, then it takes a significance because most of these Colles fractures have a very typical presentation and a very typical fracture pattern. So once you see these patients, then these patients are almost always seen in a postmenopausal osteoporotic females. And so whenever we see these patients, normally we advise DEXA scan, but even without a DEXA scan, we start treatment because this is the first point of interaction with us. And as we know that most of these patients are mostly concerned about fractures. they are not very concerned about the osteoporosis treatment. So we don't want to waste, like most of these fractures, like we use anti-resorptive agents which have some disadvantage with the fracture healing as well. So there is a lot of debate whether it should be started at the time of fracture or it should go after like 4 to 6 weeks when the fracture has become sticky. But because most of these patients are basically, because most of these patients are not following up very commonly after the healing of fractures. So it's better that we start at the first interaction with them.
The bisphosphonate holiday, would you like to talk about that? Because I see patients endlessly on bisphosphonates, and it's a very long-acting drug and tends to remain in there. So, do you give a bisphosphonate holiday after 1 or 1.5 years? Both of you can answer, both the panelists.
Ma'am, in my practice, I usually give a drug holiday after 2 years maximum. So I don't use bisphosphonates after 2 years until unless we have a specific indication to continue with it. And in my practice, because getting patient for that, because I work in a public sector hospital, so getting patient for just after the fracture is healed, getting the patient for that injection is sometimes very difficult. So I usually use most commonly an oral bisphosphonate for that.
So for
Why
my practice in those on steroids, of course, I continued for longish, maybe 2 to 5 years. But generally, those who are stable, and we give a holiday after 2 years only.
So that actually answers the question given by Dr. Ashish Goel, that which specialty to initiate the treatment, gynae, ortho, medicine, endocrine, or rheumatologist, as each specialist may have their own preferences. So as we can see, each one has a different practice approach. So we can, depends on the how the patient presents and what is the clinical scenario, we can decide how to go about the treatment. And we have another question which is open to all. This is about a 52-year-old female post-menopausal having a T-score at the level of the spine of minus 1.4, femur is 0.7, and forearm is minus 0.1. So the question is whether denosumab is advisable or not.
अभी जो बंदी
Either of
रखूंगा
either of the panelists can take this question.
So what is the T score is minus 1.4 at vertebral,
At the
and
femur, yeah, ma'am. Forearm
at
is
the
0.7.
femur is. But any other risk factor other than she's 52 post-menopausal, any fragility fractures?
Haven't mentioned, ma'am. They haven't mentioned.
So here, at this point, I think we need to assess the risk. There is,
Yeah,
from my point, if I have a rheumatoid patient or if I have a
yeah.
vasculitis patient, and I am giving steroid, even for high dose for 1 month or maybe the low dose for 3 months. There, of course, I will like to have some protection. But I think our endocrinologists are the best people who can answer this.
Now, what about frac score? How many of us are calculating frac score and then treating the patient?
When I
Yeah,
started my practice, I was really, really enthusiastic and was doing fracks very well. But, it is so difficult to have that time to, always do it in OPD practice. So now I don't do it.
So, when you say chronic use of steroids, what do you mean? More than 3 months?
Yes, ma'am. 3 months.
Yeah,
Minimum
yeah.
any 5 milligram more than 3 months will be steroid
So,
induced
Dr. Anuba, what
osteoporosis.
about frac
Yes,
score
ma'am.
in your practice? You're calculating because people who have ovarian malignancies, have bilateral oophorectomies, premature menopause,
Yes, ma'am.
menopause
Yeah.
before the age
Uh,
of 45, or
yes,
perhaps
it's
hysterectomies, all
uh,
these patients we should target. And
yeah, ma'am.
also, yeah.
Definitely, very nicely put that we should. I know it's a bit busy OPD, but that's a good 10-year risk assessment
Yes,
score.
yes. So I think I
And
do it.
before that, also we need to do BMD to initiate
Yeah.
anti-osteoporotic management. I think our orthopedician colleague have pointed out. But yes, I think Jayashree ma'am will also agree to me. This I know it's like most of our institute we don't have DEXA scan, so it's slightly difficult for us. But this FRAX score assessment, as you mentioned, should be initiated. And once you want to give anabolic steroids, or like ma'am said, because bisphosphonate should be the first line of treatment. And when you want to put on denosumab, so we should at least have the FRAX score. Like in this patient, 1.5 without any comorbidities. You really need to look whether you want to initiate it or not.
Right. Now, a few lines about calcium preparations. And one common question, Dr. Anubha, people
Yes,
say,
ma'am.
I have kidney stones. Can I take calcium? So, usually they are calcium oxalate stones. So, can you kindly
Yes.
talk about that? And also, which calcium preparations can be given with meals and which can be given irrespective of meals?
Ma'am, as you have already talked about calcium carbonate and calcium citrates, so the calcium carbonates definitely can be given with meals, and this for tendencies of forming urinary, we have to look at the calcium levels also. We have to look at the urinary calciums also. So, in general, supplementation should not be given, but the preparations are quite safe and can be effective. Both the carbonates and the citrates are available, and they have to be given. We actually are deficient both in vitamin D deficient as well as calcium deficient specifically in the post-menopausal age group.
Dr. Pooja, there are two very important questions in the chat box.
Yes, sir. I was about to come to that. We have a question from Dr. Kathy. It's what about aromatase inhibitors induced osteoporosis, and how long biphosphonates should be given? Any alternative protocol? So, any of the speaker or panelists would like to take that?
All the chemotherapeutic
Yeah.
agent.
Yeah.
There. Yeah, ma'am, please you take it. Ma'am.
Yeah, I like to answer that. This bisphosphonate you can give for 5 years. Highest this the best regimen is that the anabolic therapy for 2 years, like that of the teriparatide, followed by the anti-receptive like bisphosphonate for these 5 years. The maximum. After that, you can go for the drug holiday. If high risk category, then 1 to 2 years you can give drug holiday. If the moderate risk category, you can give the 2 to 3 years drug holiday. And during that drug holiday period, you should go for the BMD estimations, intermittent BMD estimation, yearly or two yearly. If there is decrease of the BMD, then may you go for this again you start this treatment. So bisphosphonate highest literature is giving that you can give up to 5 years, not more than that. And you may
Thank you.
nowadays you may switch to the denosumab. Denosumab after bisphosphonate, you may go for the denosumab.
Thank you, ma'am. There is another question from Dr. Ashish Goel. This is a follow-up question from his previous. For example, a patient is on biphosphonates for 1.5 years from the orthopedic physician and now comes to the internist and he wishes to start denosumab and to stop biphosphonates in a stable patient, considering once in 6 months dose in a post-menopausal patient. So what is your opinion on this, ma'am?
That things we have discussed. You can
Already,
stop this
ma'am, told you.
bisphosphonate and denosumab. You can go for that.
Yes, yes.
It's a
Okay.
newer molecules. Side effect is less. Hypercalcemia is less. So that you may go for that.
And the only thing is denosumab should not
It's
be
a cost.
stopped abruptly also. Yes, ma'am. The rest is,
Cost.
yes, the cost is
Cost
there.
and abruptly, it should not be stopped abruptly, and it will lead to the fracture. Once you have mentioned clearly in one slide, one of
And
your
I think,
slide.
ma'am, you've already, there is another question. What's your experience with injection teriparatide? I think you've already discussed that. So would you like to add anything to what you've already mentioned?
No, 2 years of the teriparatides, 20 micrograms daily for 2 years of the teriparatides. If there is no contraindications, it is good. Followed by that of the other anti-regenerative therapy. Before that, if you want to stop, then thing is that BMD improvement may not be there.
Thank you, ma'am. Thank you. I would now like to hand over to Dr. Divya Saxena to give the concluding remarks and to thank all the speakers and panelists for an enriching discussion.
Denosumab is safe in CKD. Yeah, the last question. We can
Yeah.
definitely
Yeah.
keep on
I
continuing.
missed that one. Yeah. Okay.
Thank you so much, Dr. Pooja. And I must thank Dr. J.K. Sharma, sir, for this wonderful initiative and creating this women wing under IPF. And I must congratulate also Dr. Princey Jan and the whole team for starting with a bang and choosing this very important topic related to women health. We all know that risk of osteoporotic fracture is a major healthcare concern for the women, and moreover the impact is so much on the quality of life also, and the society also. The cost of the treatment and the cost of the rehabilitation is also much for such kind of patients. So we should take an initiative, and we all should take a pledge kind of thing ki, every menopausal patient coming to our OPD, especially females, we should at least ask a small brief history about any high risk factors. And if we cannot advise for the DEXA scan, at least we can do the FRAX scoring, very rightly said by Dr. Anupa. It is easy to done at our OPD level. So just everything has been discussed in so much detail, and very clear concepts are given by both the speakers and all the panelists. Just few pointers that we should screen. The guideline says the menopausal women and the 65 years and more, and if the female is less than 65-year age and having high risk factors, we should screen that female. We should screen males also. We should not forget the males also. They can also be osteoporotic, and the screening is definitely the gold standard is DEXA scan, but certain other laboratory investigations should also be done, like vitamin D, the calcium, and the creatinine score should also be done. And the treatment, we have so many options available, starting from the age old treatment options available, and the very newer drugs available these days. Dr. Jayashree Nan has told all of you the very much in detail. And regarding the estrogen therapy and the HRT therapy, we have to really select the patient whom to give the single therapy or the combination therapy, and when to start the treatment and when to stop the treatment. All these things are very much important. The most important thing is to screen the patient and to act at the right point of time, so that we can reduce the disease burden and at least the risk of fractures in all the women and the males also. Thank you so much once again to all the panelists and the speakers. Now I would hand over the mic to Princey, Dr. Princey.
Thank you, Divya ma'am. So now as we move towards the end of the session, academic event, it's my proud privilege to present the vote of thanks. I extend my heartfelt gratitude to Dr. J.K. Sharma sir for his mentorship, constant encouragement and guidance to us. My sincere thanks to Dr. Meena Chabra ma'am for her guidance and spearheading the women wing with such dedication. My heartfelt appreciation for Dr. Anubha ma'am and Dr. Jayashree Swain ma'am for their practical and insightful presentations. And a special thanks to our guest faculty, Dr. Vishal ma'am and Dr. Devesh, for such an enriching discussion. And special thanks to Dr. Pooja ma'am for such a seamless moderation. I thank I thank all the executive committee members and organizing team who made all the efforts for this webinar and made it a success. And finally, a heartfelt thanks to all the participants for their active involvement and making this session a success. So this is just a beginning, and we look forward to many more academic interactions like this under the banner of IPF Women Wing. Thank you all for attending and being a part of this webinar. Have a
So
wonderful
before we
evening.
disperse, there are two, three important announcements which I would like to make. First of all, extend our heartfelt thanks on behalf of the IPF uh, Executive Committee to all the office bearers and the members of IPF Women's Wing, all those who have attended. We have our annual 8th International Annual Conference on 29th and 30th of August 2026. All members of IPF, they will be registered complimentary. Everyone who becomes a member now also, and now the strength of IPF Women's Wing has gone to 110. When we started, it was 100. So 10 more females or women have joined this. Second thing is that we have started the associate membership of IPF for the first year, second year, and third year postgraduates by 50% of the membership fees. And when they complete their tenure, then they can take the full membership, life membership, by paying the remaining fees. Whosoever becomes the member, whether associate member or the life member, they will be given complimentary registration for this conference. And this conference scientific program, we are under development right now, and it has already gone to the Royal College of Physicians of Edinburgh, and most likely we may have the accreditation from the RCPE Edinburgh. So with that, and this is just the start, we will be having more webinars, both from the both wings, from the IPF women's wing as well as from the IPF men also, and we will select the topic accordingly. So with that, thank you everyone. Please, there is a very important thing regarding the feedback. So those who want to give the feedback, please do so. Members can put directly to Dr. Princey Jain, or others they can give it on to my WhatsApp number. Thank you very much.
Just before you close, JK,
Yes, sir.
my compliment to you for starting the women wing, and the beginning has been done so well of the women's osteoporosis post-menopausal. You need
Thank
to
you
be
very much, sir.
complimented for your well done.
This
Well
is
done.
all your blessings to we all.
Yeah. My best wishes to you.
Thank you, sir.
Thank
Good
So
night,
now,
everyone.
now we can discuss. Second thing is that this is available on the YouTube also. It has been recorded and it is available on YouTube. So those who could not join, they can watch and listen on the YouTube channel of IPF. Thank you.
Thank you.
Thank you. Thank you very
Thank
much.
you, everyone.
Thank you, everyone, and good night
Good
to
night.
all of
Good
you.
night.
Good
Good
night,
night.
everyone.
Good night.
Thank you, everyone.